Welcome all of you to this live program at Orthopedic Principles. Today, our guest of honor is Professor Wolf Petersen from Berlin, Germany. Professor Wolf Petersen is the Director of Orthopedic Department at the Martin Luther Hospital, Berlin, the academic hospital of the Charité. He specialized in sports trauma, osteotomy, and arthroplasty and is certified by the German Knee Society. He's a past president of the German Knee Society and vice president of the German Sports Trauma Society, as well as he serves on it as the board member. He's also the chief editor of the Knee Journal and serves as editorial board member for Operative Orthopedics and Traumatology, as well as Arthroscopy, the journal of the AGA. He's published widely and has more than 400 PubMed listed scientific publications to his credit. If you noticed, Professor Petersen has delivered a couple of lectures on our channel and it's already reached a huge audience. And today is my great honor to bring back Professor Wolf Petersen for this wonderful live program. Over to you, Professor.
Yeah, thank you. Thank you so much for this kind introduction and also for the invitation. And it's a big pleasure to talk about meniscal repair techniques. So if you have a mobile device, you can take your mobile device parallel to the lecture. And because I have prepared several QR codes within the lecture, with these QR codes, you get access, for example, to some papers, published articles, or videos on my YouTube account. So these are the QR codes of my Instagram account, and on the right is on the left is a Instagram account of the International Knee Academy, which is an orthopedic training platform for knee surgery and knee problems, and on the right is my personal Instagram account. Okay, but let's talk about the meniscus. Let's start with the anatomy. The meniscus, medial and lateral, are movable joint surfaces. The function of the meniscus is load transmission and stabilization of the joint. And when in case of loss of the meniscus, the consequence is overload of the joint, which leads to osteoarthritis. You can see it here on the right. Loss of the meniscus and severe osteoarthritis with cartilage damage and osteophytes. So that's the rationale for restore or for meniscus therapy. The main principle is restore the meniscus if possible. Another X-ray, you see here a patient 10 years after ACL reconstruction and medial meniscus resection, and what we see here is the large osteophyte, joint space narrowing, and even varus deformity, intra-articular varus deformity. So another example how important the meniscus is for load transmission, and the long-term consequence is osteoarthritis. So again, repair the meniscus if possible. I will start with this drawing. This is a consensus project of the knee ligament committee of the German Knee Society, where we wanted to figure out how osteoarthritis develops after ACL injury. And when we look to the development of osteoarthritis, we should not look only to the ACL injury. We should more look for the knee trauma, because during the knee trauma, not only the ACL injury occur, we have also associated injuries such as cartilage injuries, meniscus, or peripheral ligamentous injuries. And especially the meniscus is very important for the development of post-traumatic osteoarthritis. That is the reason why ACL reconstruction does not always prevent osteoarthritis in patients with chronic anterior instability if the meniscus is not adequately treated. Therefore, it is very important to address the meniscus lesion in case of an acute ACL injury properly by meniscus repair. Some basics. The this is a schematic drawing showing the arrangement of the collagen fibers, and on the right you can see a scanning electron microscopic image. This is from my thesis back from the 90s. And this collagen fiber texture is has some clinical relevance, especially regarding meniscus suture, because the force which acts on the meniscus tends to extrude the meniscus to the outside, but the meniscus cannot resist to this extrusion because it's fixated in the region of the anterior and posterior horn. But that leads to this circular hoop stress. And when we have an injury or a tear which is parallel to these circular fibers, then this lesion, the stress on this lesion is low, and so this lesion has a good potential for repair. The other thing is true when we have a small or a longer radial tear, which is in a 90-degree or perpendicular angle to those circumferent fibers, then there is a maximum stress on the meniscus suture, and the prognosis of a radial tear is maybe not as good. And the other anatomic finding or the other anatomic structure which we should have in mind when we talk about indication for repair is the blood supply. And here you can see a cross-section through a meniscus, and you can see that the joint capsule adjacent to the meniscus is very well vascularized here. This was a specimen which was injected with ink, and you can see here these small black structures are the blood vessels, and the blood vessels penetrate the basis of the meniscus from the joint capsule, and we can divide the meniscus in 3 different zones. The big white zone here in the central part here. This is the avascular zone. Here the meniscus tissue has a poor healing potential, in contrast to the outer zone, which is the red zone, and the zone in between is a so-called red-white zone. And in general, meniscus repair is normally recommended in this red, white, and red zone. So tears in these zones have a better prognosis than tears in the white zone. So when we talk about repair, it's always we have always to consider so-called pro criteria and contra criteria. And so pro criteria are, for example, tears in the red or red-white zone, longitudinal tears, as I have shown you, but also acute lesions or lesions in patients with younger age. So contra criteria are tears in the white zone, possible retraction of the torn fragment, degenerative changes in the torn fragment, or poor tissue quality, radial tears, chronic lesions, and higher age. And it's very important to consider all these factors, because the failure rate after meniscus repair is pretty high. So these are 2 examples. This is a radial tear. So from the tear morphology, not the best criterion, not the best tear morphology to perform a repair, but the patient is pretty young, 19 years old, high-level athlete. That's why I decided in this case, we have several pro criteria which overweight the radial tear, which could be considered as a contra criterion. And in this case, as you can see here, I decided for a repair. In this case, I did a partial resection, and then did an outside-in repair with 2 horizontal sutures. Today, maybe I would have added 2 additional vertical suture to perform a so-called hashtag repair, because several newer studies have shown that this repair has a little bit higher biomechanical stability, but it healed also with the two horizontal tears. So this patient went back to sport after 5 months and very successful. This is another case, traumatic meniscus lesion. In this case, the indication is clear. This is a bucket handled here. You can see here the displaced meniscus fragment in the notch. Here's the PCL, here's the ACL. It was a combined ACL and MCL rupture. So here we have only pro criteria. The patient is pretty young, 17 years. He has a peripheral meniscus injury with a tear in the red-white zone, a very large meniscus fragment. So this and good tissue quality. So this case would also be an ideal indication for performing meniscus repair. So in this case, we have no contraindication criteria. So ideal indication. When we talk about repair techniques for the normal meniscus tear, so we differentiate so-called outside-in techniques, inside-out, and all-inside techniques. And the all-inside techniques, can be divided further into suture anchor techniques and an all-inside repair with a hooked needle via the posterior middle portal, but I will come later on that technique. I start with the classic technique. In my hands, this is the outside-in technique. It's a very easy technique. You only need 2 cannulas or two needles, puncture needles, and you penetrate the meniscus base with the first needle, and with the needle you can introduce the suture into the joint, and then you penetrate the meniscus with another needle where you have a suture loop, which ideally has another collar, and then you pass the first suture through the suture loop, as you can see it here, and then you pull the loop back to pass the suture out of the joint, and then you can tie a knot to at the joint capsule or at the base of the meniscus to repair the meniscus. Here with this QR code, you can see a video which is on my YouTube channel. You can see the surgical technique, but I will show you a longer video of a complete meniscus repair in a few minutes. So the advantages of this outside-in technique is it has biomechanically a very high stability, and it is quite cost effective because you just need these both puncture needles and suture material, braided suture material 2.0 and this suture loop. Here you can see some arthroscopic images. Here you see the loop. Here you can see the needle with the braided suture. I always use braided suture material for the meniscus repair, but you can also braided non-resorbable suture material, but you can also use, for example, PDS, which is a long resorbing resorbable suture material, and which is non-braided suture material. It works also, but my personal preference is this braided 2.0 suture material. In this case, we used fiber wire. And you can see here, I placed 2 vertical sutures into the meniscus here in the intermediate part of the meniscus, and this outside-in suture works very well. It should be the basis for every arthroscopic surgeon. The next technique I would like to talk about is the inside-out technique. This is in America. This is the classic meniscus repair technique, you need some special instruments for this. You need long needles that are connected to suture material, for example, fiber tape in this case, or and you need a special cannula to apply or to maneuver these needles in the joint. So you penetrate the meniscus here from the anterolateral portal, and so to pull the suture out of the joint. Then here it's a posterior medial aspect. You need a little incision to make sure that you do not injure the saphenous nerve, and then you penetrate the meniscus with a second needle. Can place a horizontal or vertical suture, and pull the needle out of the incision, out of the posterior medial incision, and then tie a knot to perform your meniscus suture. The only disadvantage is you need special instruments for this surgical technique, so it's a little bit more cost intensive as compared to the outside in technique. That's why the outside in technique is for me in nearly all my cases I use the outside in technique. The advantage of the inside out technique is that you have to perform a posteromedial approach. It has not always to be as big as here, but it should be large enough to visualize the saphenous nerve, or to visualize the needles, to make sure that the needles and the suture material does not entrap the saphenous nerve, like is shown here. With these both needles, you would have, or you would produce an entrapment of the saphenous nerve, which can induce some problems, such as chronic pain syndrome, etc. To overcome the risk of nerve and vascular injury in the posteromedial and posterolateral corner, you can also use these all-inside implants. All-inside implants are mostly connected to a device, and they consist of mostly of two either peak anchors, which are connected to suture materials, which is also connected by a self-blocking knot. And you see here in this paper of Grant and co-workers, they have shown that the prevalence of nerve injury and irritation was much higher when you performed the inside-out technique compared to the all-inside repair. The next image, or the next slide, shows you schematic drawing how these all-inside devices work. With the instrument, you penetrate the meniscus to push the first anchor behind the meniscus, the capsule, or the base of the meniscus, or behind the joint capsule. Then you penetrate the meniscus again to release the second anchor. Then you tension your suture with a self-blocking knot, and yeah, finally with the repair. There are many different devices on the market: fiber stitch, air by Stryker, and the fast fix of Smith & Nephew. I have good experience with all these implants. This is the Stryker Air, for example. And with this QR code, you have access to a video. In most cases, you need more than one repair technique. For example, these all-inside implants for the posterior part of the meniscus to reduce the risk of neurovascular damage. But here in the intermediate part, you can use all three all inside out, and outside in techniques very well. And I prefer the outside in technique in this region because it's cheaper and has very good biomechanical properties. And in the anterior part, you can only use the outside in technique because it's very hard to place other sutures here with the other devices because of the location of the tear. So in most of the cases, we perform a hybrid repair, and I will show you a video now. Wait, sorry. Okay, it starts. You can see here a bucket handle tear. Here's the bucket handle tear. No, it does not work. Let's wait a little bit, but if it does not work, you can scan this QR code here. And via this QR code, you come to my YouTube page, and via YouTube, you have access to the full video of the meniscus repair technique. This video shows a hybrid technique using all inside technique to repair the posterior part of the meniscus, an inside out technique for repair in the intermediate part, and an all outside in technique for meniscus repair in the intermediate part. Let's check. When I tested it, before the Zoom conference, it worked. Very, very sorry. No, then maybe the file is too.
Prof, you can continue. Maybe we can run the video at the end once again.
Okay, maybe yes. Okay. Then I continue with a systematic review about long-term results we published 4 years ago, and we found that the failure rate after meniscus repair, the 10 years failure rate is pretty high, 22%. We have also always have this in mind when we make the indication for repair or not repair. But I think with regard to the chondroprotective effect of the meniscus repair, this long-term failure rate is quite acceptable. And what we also found is that the failure rate also depends on the repair type. So the highest failure rate was observed in patients with isolated bucket handle tears. There, the failure rate was up to 50%. Therefore, in these tears, we have to be very careful with our indication. And to improve the healing rate or decrease the failure rate, we have several adjuvant therapies or procedures such as trephination of the meniscus with a K-wire or a needle, a suprameniscal synovectomy, or also a microfracture in the notch to stimulate bone marrow cells to come out into the joint to stimulate or to induce a healing environment for the meniscus. And this healing environment we normally also find when we perform a simultaneous ACL reconstruction. And this study by Haas and co-worker has shown that the re-rupture rate of an isolated repair could be decreased from 20 to 9% when we perform the meniscus in combination with ACL reconstruction. Two factors may be responsible for these findings. First, stability is a better environment for the meniscus to heal. But the other thing could be, as I showed you at the previous slide, that the growth factors which come into the joint due to drilling of the femoral and tibial tunnel could also stimulate healing of the meniscus, as you can see it here. So these two factors, stability and growth factors, may be responsible for this observation that the re-rupture rate is much lower when we perform meniscus repair in combination with ACL reconstruction. So this is my an algorithm for the management of acute ACL injury. Because the meniscus injury, as I showed you in the first algorithm, the meniscus injury has high influence on our management, because if we have an repairable meniscus lesion, then I would go for an also for an acute meniscus repair in combination with ACL reconstruction to preserve the meniscus and with a goal to prevent osteoarthritis. All other patients, if they're not high-level athletes or have other indication criteria, can go for a non-operative rehabilitation program to test later on if they are COPA or non-COPA. If they are COPA, they can proceed with the non-operative therapy. Non-COPAs should be operated as well by ACL reconstruction. And when we have the situation that the COPA failed, and one failure would be the meniscus, secondary meniscus injury, then we also should go for ACL reconstruction. So what about ACL and meniscus injury? This is a large study from Luxembourg by Margosch and Seil, and they looked to 239 ACL injuries and found that a high percentage, 67%, showed additional meniscus injuries. And 52% of these injuries involved either the medial ramp and or the lateral meniscus root. So let's talk about ramp and root lesions. Let's start with the ramp lesion. The ramp lesion has first been described by Michael Strobel, to my knowledge, in his book at the end of the 80s. And the medial meniscus ramp lesion is, by definition, a lesion in the of the meniscocapsular ligaments, the meniscus capsular ligament and the meniscus tibial ligaments. And it is always, nearly always, associated with ACL injury. And this study, also from Luxembourg, Mouton and Seil, they have shown that when we have a meniscus ramp lesion, then the prevalence of a high-grade pivot shift is much higher than in the group without a ramp lesion. So this is a clinical rationale to say that the medial meniscus ramp lesion contribute to anterolateral or anteromedial instability. How to diagnose a ramp lesion? Diagnosis, the preoperative diagnosis, is not so easy, because normally the ramp lesions are very difficult to detect. This is an MRI. You can see here the meniscus. Here you can see the abnormal signal at the base of the meniscus. So in this image, you can see the ramp lesion, but quite often it is not as ideal visible, as you can see it here in this MRI, and the only indirect sign is normally this posteromedial bone bruise, as you can see it here. That's why you should try to perform an arthroscopic diagnosis in your cases. Again, we have a video, but it does not work, unfortunately. So because this video shows the so-called trans-notch views or the Gilchrist view. And for this Gilchrist view, you introduce the arthroscope or you push the arthroscope to the posterior portal by pushing it in between the medial femoral condyle and the PCL. Here's the PCL, this is medial femoral condyle, and you push it to this little hole here in between these structures. So I perform this bone bruise nearly in every ACL patient nowadays to diagnose these injuries. This is a classification by the French group of Tonard, and he divides 5 different types: type 1, 2, 3, 4, and 5. So I have some criticism with I'm sorry, with this classification, because only this type 1, or in my opinion, only this type 1 is a real ramp lesions. All the other are ramp lesions plus longitudinal peripheral tear. And maybe this complex classification explains the high rate of ramp lesions found in all the French studies. In my clinical practice, the rate of ramp lesions is not as high as, for example, the group of Bertrand Sonnery Côté. They showed a rate of ramp lesions up to 20 to 30%, and that's much higher than I observe it in my clinical practice. When we have a ramp lesion, it's very important to diagnose the real ramp lesion, because if we have a real ramp lesion, it is very hard to perform a good repair. It is possible, but it's quite difficult with these classical all-inside devices. You can see it here in the schematic drawing. You normally penetrate the meniscus with your device above the lesion, and then you deploy the anchor here above the lesion, but you perform no repair. This study also by this French group around Tonard, they have found that when you perform a meniscus repair with this all-inside meniscus anchor, you have a 2-fold higher failure rate when you compare it to patients who patients group with a so-called suture hook repair via the posterior portal. And the next slide shows you this suture hook. This is the so-called Gilchrist view. You can see here the ramp lesion. Here's the medial femoral condyle. This is the base of the meniscus. This is the meniscus capsule. Here is the posterior portal. And this is a cannula or a suture hook device, which is introduced through this posterior portal. And then you penetrate first the meniscocapsular ligaments, and then the base of the meniscus here. And then you can forward the suture material. I use also mostly braided suture material for this posterior suture hook repair, but you can also use a non-braided absorbable PDS suture for that. And then you pull both sutures out of the joint, perform a gliding knot, and then you push the knot down to your to the base of the meniscus, and then to secure the sliding knot with 2 half hitches. you can see the suture here, and then you add, in most cases, one or two, so that you have 2 or 3 sutures to reduce or repair ramp lesion. The next question is it necessary to repair all ramp lesions? This group from Asia around Liu, they because they have shown that if we have a stable ramp lesion, which means that you have no excesses anterior translation of the meniscus fragment when you probe it, then it doesn't matter if you perform a repair or not, because there was no difference in PROMs, knee stability, meniscus healing status between just abrasion and trephination alone or a surgical repair. That's why I use this algorithm for the repair of medial meniscus ramp lesions when I perform an ACL reconstruction. I do this trans-notch view in all of my patients. And when I find a ramp lesion, I test if it's a stable or an unstable ramp lesion. If it's stable, and in combination with an unstable longitudinal tear, which is a normal longitudinal tear of the meniscus, then I would do an all-inside repair with a suture anchor device. Stable ramp lesion, just a trephination or abrasion is enough. And when we have an unstable ramp lesion, I perform an all-inside repair with suture hook via the posteromedial portal. Yeah, let's talk about root tears. This is again a video. I think it does not work, but per definition, a medial meniscus root tear is a lesion which is an avulsion of the meniscus from the insertion zone, a radiate tear within 5 millimeters from the insertion by definition. And when we look to or compare medial and lateral meniscus root tears, then we find that medial and lateral meniscus root tears are complete different entities. In the medial root tear group, the age is higher, 57 versus 33. BMI is also higher, 30 versus 25. Gender male-female relation is rate is also different, and patient in the medium meniscus root tear group has a higher rate of osseous deformity, varus malalignment, a hip knee ankle angle of a mean hip knee ankle angle of 5.6 degrees versus 2.4 in the lateral meniscus root tear group. Trauma here only in 7 patients. In the lateral group, 45 patients. And ACL, the ACL injury was also, the rate of ACL injury was very high in the lateral meniscus root tear. In contrast, the OR, osteoarthritis grade, was higher in the medial meniscus root tear group, and also the incidence of spontaneous osteonecrosis of the knee or insufficiency fractures, which is a more it's a newer name for this entity. So in conclusion, the medial meniscus root tears are spontaneous injury due to medial overload, while the lateral meniscus root tears occur in younger patients, are traumatic injuries and associated with ACL rupture. So these are the typical MRI signs. At the medial side, we mostly find the ghost sign, which is shown here, with this white appearance of the meniscus triangle, white like a ghost. Then the linear defect, as you can see it here in the middle, or some indirect signs, the extrusion of the meniscus, and per definition, an extrusion of more than 3 millimeter is a relevant extrusion, and Another indirect sign is the bone marrow edema, which you can see here at the medial, below the medial tibial plateau. And main clinical symptoms of a medial meniscus root tear is sudden joint line pain. At the lateral side, the meniscus root tears are mostly asymptomatic. What is the biomechanical consequence of a root tear? It's its extrusion, especially on the medial side, and because the meniscus is displaced medially when the root fails, or when the insertion of the meniscus fails. And this meniscus extrusion is associated with a high increase of medial joint load. And this increase is nearly as high as it is observed in patients with the medial meniscectomy. So the biomechanical consequences of these medial meniscus root tears are very severe. In contrast to the lateral meniscus, at the lateral meniscus, we differentiate three different types of root tears. It's a classification which has been proposed by Philip Forkel. So we differentiate the type 1 root tear, which is an avulsion, a typical avulsion of the meniscus from the insertion with an intact medial meniscus meniscofemoral ligament. The type 2 tear is a so-called parrot beak tear, which is an oblique tear pattern, also with an intact meniscofemoral ligament. And the type 3 injury is in either a type 1 or type 2 tear in combination with an injury of the medial meniscofemoral ligament. And in these both types, the type 1 and 2, we observe no increase in lateral meniscus joint load and lateral joint load. Only in the type 3 injury, with an injury of the meniscus femoral, we observe this increased joint load. But we also found in biomechanical studies that all these lateral meniscus root tears contribute to rotational instability, anterior instability. Therefore, in our clinical practice, we try to repair all those lateral meniscus root tears, although only the type 3 root tear increases the lateral peak joint pressure. How do we perform lateral meniscus root repair? You can do it in two ways. My preferred technique is this. I augment the posterior horn of the meniscus with braided suture material, and then I pull these sutures into my ACL tunnel, and then I fixate these sutures together with my ACL in the tibia, and with this technique I can reduce the root tear. Here is the insertion zone, and then the meniscus can heal here to the insertion zone. This technique works very well, and it's not as complicated as it is when you drill a second tunnel, where the risk of tunnel confluence is pretty high. So this is definitely my preferred technique. Yeah, I'm sorry, another video which is probably not working. This shows how to repair type 2 lateral meniscus root tear. And for repair of the type 2 lateral meniscus root tears, they all heal. You should be very generous with your indication. I use normally 1 or 2 all-inside implants to perform the repair in these patients. Medial meniscus root tear. For the medial meniscus root tear, the so-called transtibial pull out suture is a preferred technique. You have to augment the posterior horn of the meniscus with braided suture material, and then you pull the suture material through a tunnel which has been drilled from the anterolateral side to the insertion, posterior insertion of the medial meniscus, and then you pull the suture out of the tunnel, and then you can do a refixation here over a suture, over an cortical button. Many studies have shown that the results are pretty good after this repair technique, but in some patients, even if you have performed this transosseous repair, you have still some extrusion. That's why Japanese guy Koga introduced the so-called centralization procedure, which should reduce the extrusion by fixing the meniscus to the edge of the tibia. And he described it first for the lateral meniscus, but I think it makes more sense to perform this at the medial meniscus, because extrusion plays a bigger role at the medial meniscus. At the lateral meniscus, the extrusion is in most cases is not as severe as you can see on the medial side, and this and the cause for this is maybe the still intact meniscofemoral ligaments in most of the cases. But at the medial side, it makes sense. You can do it either by a new transosseous tunnel or by using a suture anchor, which is placed here at the outer part of the medial tibial plateau. This shows a typical root tear patient. You can see it here, the varus deformity, a little bit obesity. The question is, yeah, would you, and in insufficiency fracture here, it's a medial femoral plateau. And the question is, yeah, would you do a repair in this patient, a repair alone, or would you combine it with another surgery? And in those patients with combined osseous deformity, varus deformity, I perform an osteotomy to correct the malalignment of the leg, and then I perform it in combination with root repair. And the rationale is given by the systematic review, which has shown that the results are much better. The patient-reported outcome measures and the healing rates are much better if you perform or combine your medial meniscus root repair with an realignment procedure. So this is an algorithm for medial meniscus root tear. I differentiate if I have a traumatic or non-traumatic tear. In most cases, it's a non-traumatic, but in these rare cases of a traumatic medial meniscus root tear, I do a repair, or I try to do a repair, a transosseous repair. And in the non-traumatic, I look for the cartilage degree, the cartilage damage, or the degree of osteoarthritis. In cases of osteoarthritis 0 to 2, and if there's no varus deformity, I go for a repair. If there's a varus deformity of more than 3 degrees, I perform osteotomy in combination with repair. If it's higher degree of osteoarthritis and more than 3 degrees of varus in active patients below 60, I do an osteotomy alone. If I have a 4 degrees, fourth degree osteoarthritis, I probably would go for an unicondylar joint replacement, which can also be performed if you have a non-active patient and predominantly articular deformity, or patients which are older than 60. Rehabilitation. after meniscus repair. It depends on the tear and repair type. In small tears below 20 millimeters in combination with ACL reconstruction, I use my normal ACL RIA protocol, 2 weeks partial weight bearing, and a criteria adopted RIA protocol and range of motion is tolerated. When I have a larger longitudinal tear, in maybe more than 20 millimeters in combination with ACL reconstruction, I use a restricted ACL RIA protocol, 4 weeks partial weight bearing, criteria adapted RIA protocol, and 4 weeks restrictions of the range of motion to 0, 0, 60 degrees, and then 2 further weeks with 0, 0, 90 degrees. If I have an isolated bucket hand, I'm a little bit more careful. 6 weeks partial weight bearing, 4 weeks range of motion, 0, 0, 60, and 2 weeks 0, 0, 90. And when I have a medial meniscus root tear or radial tear, then I would advise the patients to perform 6 weeks non-weight bearing. In most cases, I use a medial and loader brace, and also in combination with range of motion restrictions. So in conclusion, repair the meniscus if possible. Indication criteria is a tears in the red or red-white zone, tear type, age, chronicity. These criteria are important. Then we have 3 major repair techniques: outside in, all inside, and inside out. All of these techniques have their indication. All inside devices are ideal for the posterior parts of the meniscus, outside in for the intermediate and anterior medial part or anterolateral part of the meniscus. When we talk about ramp lesions, you should know that it's very difficult to diagnose the ramp lesions on the preoperative MRI. Therefore, you should always perform the arthroscopic transnotch view in your ACL reconstruction patients, and use suture hook repair for unstable ramp lesions via the posterior medial portal. Root tears, medial root tears are non-traumatic, whereas obesity, lateral are traumatic and mostly associated with ACL injury. At the lateral side, I use a transosseous repair via the ACL tunnel, and at the medial side, I use a transosseous repair, and in case of a varus deformity, I perform the repair in combination with an HTO, and this depends on if the tears are traumatic, non-traumatic, and on the severity of cartilage and cartilage injury or cartilage damage and osteoarthritis. Thank you for your audience.
Thank you very much, Prof. Prof, you can stop sharing.
Okay.
Do you think we could go to if you can close this presentation, do you think we can go to the videos? Do you have it on your computer?
Yes.
So that we get the best to the audience.
Let's check. Oh yeah, right there on the screen. It's maybe a little bit longer version. I did a cut for a 3 minutes version, but yeah, here you can see. I'm sorry.
You
Do
need
you
to
see it?
share. Yeah.
I'm sorry. Wait. Mm,
think we can move on if this is causing delay
Just a
for the
second.
audio.
Prof is on the video.
Oh, yeah, yeah.
If it's not functioning.
No, it's okay. Let's wait for a minute. Yeah, it's there.
Okay.
Yes, Prof. Great.
So
Thank you.
this, you can see, yeah, okay. This is
Yes.
a bucket tear here, patient with former ACL reconstruction. You can see. So this is a ideal indication for me. So I started with debridement of the tear and suprameniscal synovectomy, as you can see it here. Then I performed the supination of the periphery of the meniscus to stimulate healing. This was with a microfracture all. And then a reposition of the torn meniscus fragment. And then I started with an all-inside repair in the posterior medial part, as you can see it here. This is the fiber stitch from Arthrex. And with the needle of the device, you penetrate the torn meniscus fragment and also the base of the meniscus, and you push the meniscus anchor forward. In this with this implant, it's a so-called soft anchor, and then you close both. You pull it back, and you close both suture by pulling these loops. And you tension the threads and lock the anchors. It's a self-blocking mechanism or self-locking locking knot. And after locking of the thread, you have to cut the suture. I use a normal punch for that, but you can also use a special suture cutter for that. Then in this case, for the inside out, or for the intermediate part, we use an inside out technique. I normally do not use it, but this is just for educational purposes, just to show how an inside out technique works. Here I advance with this special device, the needle through the meniscus, torn meniscus fragment, and through the base of the meniscus. You have to perform a little incision at the posterior medial side to make sure that you do not entrap the saphenous nerve, as you can see it here. Then you pull the first needle out. And when the needle is out, you can penetrate the meniscus fragment with a second needle. And both needles are connected to the suture material, which is a suture tape in this case. And here you see how the needle is pushed through the torn meniscus fragment and the base of the meniscus. And here you should make sure that you do not entrap the saphenous nerve with those sutures. And yeah, after pulling the suture material through the meniscus, you tie a knot, or you lock both threads by tying a knot over the posterior capsule or the base of the meniscus. This is also a very strong suture. And the third suture type is the outside-in technique, which was used here in the anterior part of the meniscus. Yeah, here you see how I close the inside-out suture, and then we continue with the outside-in suture for the anteromedial part. Here I perform also a little incision and then I penetrate the capsule and the meniscus fragments with the needle from outside to the inside. Here you can see how the needle penetrates the meniscus fragment. Here you see the non-braided suture material, which can be used for the suture loop, and then advance another needle and push the suture through the suture loop. Here in this case, I did a vertical suture. You can do vertical and horizontal suture with this technique, and you can place also suture here below the meniscus and above the meniscus, depending on your repair result. Here I passed the suture through the suture loop, and then and now I pull this the non-braided suture loop back to pull the suture out of the joint, and then you can perform your repair by tying the knot behind the base of the meniscus or behind the capsule. As you can see it here. And then I added one more outside in suture. So in this case, I used one all inside in the posterior part, two inside out, and one outside in technique in the anteromedial part. And I combined it with microfracturing in the notch, as you can see it here. Okay, that's the meniscus repair technique.
Thank you, Prof. So, Prof, now we got a full video presentation of the bucket handle. Otherwise, it was just a small video.
No, it was a big full video.
Right.
Yeah.
So that was an opportunity in adversity.
Yeah. You can also you have with the QR code you have access to my YouTube channel, and you can also watch it later on. Yeah.
Prof, let's take a few questions. Prof, what kind of repairs do not do well? For example, in the initial part of your presentation, you mentioned that a bucket handle tear, the reoperation rate is as high as 50%, right? In total, the reoperation rate is around 15 to 20%, right? But in the bucket handle tear, the reoperation rates are much higher.
Yeah.
And is there any other category other than the classic bucket handle? Suppose age. What about age? The higher age, the reoperation rates are going to be higher.
A very high risk group are high-level athletes with an isolated bucket handle. In my own experience, the reoperative rate is 90%. That's why in these high-level, I'd always talk with the patient, but in most of the cases, we decide to go for a partial meniscus resection or resection of the bucket handle fragment.
And Professor, have you encountered situations where there's persistent pain after doing a meniscal repair? Because sometimes you suture it from outside, right? When you're doing an inside-out repair, and the repair gets entangled into a portion of the ligament. For example, the MCL is quite broad.
Sometimes the implants can induce pain because in some cases we observe some cystic formation around the implants. It's mostly temporary pain. After some weeks or some months, I don't know. Maybe the patient adapt to the pain, but the pain intensity decreases over time in my experience. but I had also patients where I had to, and these were very rare cases, where I had to do a revision to remove cystic formations or even the implants. Prominent knots from the outside in or inside inside out techniques can also produce problems. And the most severe problem was one case I remember with an probably entrapment of the saphenous nerve, who developed a complex regional pain syndrome. This was a very severe complications, so that's why I recommend. I think I don't know. I don't know. I don't remember. I think it was no inside out repair in this case, but it was. I think it was maybe damage to the saphenous nerve by outside in sutures, but that's why it is so important, especially for the inside out technique to visualize where your needles during repair.
Thank you, Prof. Prof, we also joined by Loiy. Loiy Al-Khatib is a very prominent and upcoming orthopedic surgeon from Dubai. Loiy, welcome to the show and your questions to Professor Petersen, please.
Thanks, Professor Petersen, for joining us again and for being on the stage again from Berlin, despite your tight schedule. I know you're super busy right now. Anyway, thanks a lot. Thanks a lot. Looking forward to see you again here in Dubai, maybe.
Yeah. It would be a pleasure to come to Dubai.
It's coming, promising you. So I would believe repairing the meniscus starts with a good visualization of the meniscus. If you don't see the meniscus, so that you won't be able to repair it. So in order to get a good visualization, you need one of the issues that challenges, maybe Dr. Petersen will talk about it, as visualization of the posterior horn of a medial meniscus in ACL deficient knees. Do you have any recipes or do you have any tips and tricks for anyone who's fixing the who needs to repair the medial meniscus in ACL deficient knees? We know that the ACL deficient knees, there will be forward translation of the tibia, the femur will be translated to the posterior, pushing the ram region or pushing the posterior horn to the back. There will be locking mechanism, and or the pivot mechanism will the knee will be internally rotated, and the visualization of meniscus will be difficult. So, is there any tips and tricks that you can provide us for better visualization of the meniscus?
Yeah, I mean for the ramp repairs, of course, the trunch notch view, I think it's mandatory. And for our other kind of repairs, go into slide flexion and try not to pull the tibia in the direction of anterior tibial translation, and not, to make sure that you do not entrap the meniscus, the posterior horn of the meniscus with anterior tibial translation or rotation.
Yeah, good point. So what you measure, Dr. Petersen, is saying that just slight flexion, 30 degrees of knee flexion, external rotation. You in this technique, you might unlock the pivot mechanism, and you will have better and valgus stress as well. So we'll have a better visualization of posterior horn of the meniscus. And I think you have a low threshold to do pie crusting or the fenestration of the MCL.
With pie crusting, I love it, especially in my older patient, especially in patient with some degree of osteoarthritis. But I'm a little bit more careful in ACL injured patients because I'm a little bit scared about to increase some medial instability. I'm really careful in ACL injured patient with pike crusting. But
Is that because you are using a hamstring?
I don't know, yeah, because some of the ACL patients have also associated medial instabilities, and I don't know if it's a good idea to increase the instability by pike crusting. But in all other patients, I have very good experience with the pike crusting method.
Awesome. So the other point is the meniscus extrusion. Do you think that the root tear lead to the meniscus extrusion or the vice versa? The extrusion comes first, then the tear, the root tear. And in that case, would be the centralization would be enough and ignoring the root tear, or you think you need to do both?
Very good question. Both. We did a study in the biomechanical lab in Munich, and there we found that increasing varus stress, the meniscus extrudes. So probably, and when you look to the epidemiological data, that most medial meniscus root tears are associated with varus deformity. Maybe this deformity is an etiological factor for meniscus root tear. So our hypothesis is that with varus deformity, you get increased stress on the meniscus root, and in some patients, the root is so weak that they get a tear. But when the root tear develops, then you get an excessive medial meniscus extrusion. And the other point is then when you have the tear, then the extrusion is static. Before you have in tear, you have the so-called physiological extrusion, because when you have loading, the loading pushes the meniscus outward by maybe 1 or 2 millimeters, but then the meniscus flips back to the joint space. So we call that physiological extrusion. So I think increased load on the root by varus deformity, but also obesity or maybe overload, could induce the meniscus root tear. But when you have the root tear, you get more extrusion, or the extrusion increases.
Awesome. Thanks a lot, Dr. Petersen. I don't want to take much of your time. I know you are busy. You might go back to the clinic or operation room.
Thank you,
Thanks a
Loiy
lot.
and Professor Petersen. Professor Petersen, that was a splendid presentation, and we got a glimpse of the bucket handle repair technique, and I'm sure we could look for more in future. Thank you so much for joining in.
Yeah, thank you for the invitation. It was a big pleasure, to join this interesting format and education initiative. Bye.
Bye-bye. Cheers.